Hello, everyone, and welcome to the June 2026 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we're your co hosts for this podcast series.
Well, it's June, Alice, and I'm really looking forward to the 86th ADA Scientific Sessions that will be held in New Orleans this month. The program looks superb once again, and big congratulations to Dr. Mark Atkinson, the committee chair, and the 33 other members of the Scientific Planning Committee who've put it all together. Well done.
I echo those sentiments, Mike. There'll be something for everyone with over 200 sessions across 25 topic areas, including panels and debates and oral abstracts, and of course, major clinical trial readouts from the Transcend T2D, Triumph, Achieve, Synchronize, and Reimagine programs, just to name a few.
I'm also really looking forward to the oral abstract presentations being made by current and former students and postdoctoral research fellows. There's no better stage in our field to receive constructive feedback on your work, as well as growing and starting new research collaborations.
And backed by popular demand, we will have another podcast episode recorded live at the ADA Scientific Sessions on Monday, June 8th at 12:30 p.m. So once again, the podcast hosts from all of ADA's podcasts will assemble for this episode, and this year we will also introduce the co-hosts of ADA's latest podcast, The Points of Care, the companion podcast to the Diabetes, Obesity, and Cardiometabolic Care Journal. Watch for that episode to be posted soon after the sessions. And if you're at the ADA Scientific Sessions, please feel free to come and join the live studio audience.
Now, before we get on to our interviews, Alice, what's your question this month?
Right. So just to remind everybody, every month we've been asking a question of each other that is not something we would typically find on a professional bio anywhere on the internet. So this month, my question to you, Mike, is if you could only pick one, what is your favorite diabetes study of all time?
Oh, you always ask such tough questions, Alice. And while I have many, many favorites, I'm just going to take the one that comes to mind in the pile, which is one that has had a major impact on work that I've spent 20 years trying to understand, which is the absent glucagon response to hypoglycemia that's present in individuals with type 1 diabetes. And so this was first illustrated by Jack Garrick in a paper in Science in, I want to say, the early 1980s. And what Jack showed was that when you induce insulin-induced hypoglycemia in individuals with type 1 diabetes, there's no increase in circulating glucagon that normally counteracts the effect of insulin to lower plasma glucose and helps to restore or prevent further decline in plasma glucose. And that's an essential counter-regulatory mechanism that is absent in all individuals with established type 1 diabetes. But the alpha cells are still there in the islets. And so if you inject arginine, which stimulates glucagon release as an amino acid, you get a robust glucagon response from individuals with type 1 diabetes. And so this has, over the years, helped explain as well the postprandial hyperglucagonemia, which can contribute to postprandial hyperglycemia in type 1 diabetes. But in the interprandial periods, when insulin has been raised to lower the plasma glucose, if that insulin is there too long and at too high a concentration, by that point, the glucagon is suppressed and there's no ability in the islet in an individual with someone with type 1 diabetes to activate those alpha cells, which has been shown to be due to a lack of a paracrine signal coming from the absent beta cells within the islet. And so the exact mechanisms are still perplexing investigators, and we still haven't found a way to turn that response to hypoglycemia back on. And so anyway, that is a long-winded answer to describe a study that obviously has had a major impact on my thinking and work I've spent a lot of time on.
So the mystery continues, right? To solve the problem, but it's interesting how, first of all, it's fun watching you and listening to you describe it because you can see how all these years later it is still something that you're passionate about, or you're passionate about and curious about, and you want to learn more about. And that's what makes some of these studies cool. And hopefully, over the course of the episodes that we've been doing, Mike, somebody's been listening to something we've been describing and finding one of those studies being a trigger for what their career might look like. For me personally, it's actually just like you. I have lots of favorites, but I think my favorite is actually the Steno 2 study. So the Steno 2 study would have originally been published, I guess, 2003. And that is the study of only 160 people with type 2 diabetes, microalbuminuria, randomized to what was then considered intensive type 2 diabetes multifactorial care versus what was then standard of care, what we would now consider standard of care and substandard care. But they boldly and ambitiously thought that with 160 people, they'd be able to demonstrate a reduction in heart outcomes. And they were looking at an 8-point composite, if I remember correctly, of heart outcomes. So myocardial infarction and stroke and peripheral arterial disease. So it would seem initially when it was proposed, they must have thought 160 people, like that's not going to happen. But it totally did. And it took 8 years. But after 8 years of looking at this cohort or these two randomized groups, they were able to demonstrate significant reductions in heart outcomes with a multifactorial approach versus what was then standard care. But the coolest part of the study was they then stopped the study and then said, we're just going to watch you for the next 13 years. And for the next 13 years, both groups, please do the full multifactorial approach. So the only difference between the groups in treatment was that initial 8 years. But yet, at the 21-year follow-up, the originally properly treated group still had less myocardial infarctions, cardiovascular events, cardiovascular mortality, retinopathy, albuminuria, et cetera, et cetera, et cetera. So I always present it as this is our superhero study, right? This is the study that shows that what we do every day in the clinic in type 2 diabetes, that multifactorial approach to try to reach guideline recommended targets, actually saves lives. And the number needed to treat for death was 5, which is incredible, right? For anything we do in medicine to have an NNT of 5 for death in 13 years, but then again, we treat people for decades, is really incredible. And so this is the study that I very passionate about and educate about all the time, and to try to especially drive home to our primary care colleagues that the greatest impact is really in their office, and they get to diagnose diabetes. And if they implement this from day one, I mean, the impact is tremendous.
Yeah, Allison, very much like the DCCT taught us in type 1 diabetes,
Hmm.
there are 6 years of intensive management and here 8 years, but that window of really getting out of the gates with aggressive measures to do the best you can to safely control glycemia with whatever tools are available to you at that time can really have long-term impact and benefit for our patients with diabetes. So that's a great one indeed. And so on that note, why don't we launch into the June 2026 episode of Diabetes Care on Air? We'll each conduct an interview with authors of feature articles as per our usual, and that'll be followed by a rapid exchange segment where Alice and I will each pick 3 articles of interest to us.
And to quote Pink, let's get this party started. One of the feature articles from the June 2026 issue of Diabetes Care is an important position statement from the European Association for the Study of Diabetes, EASD, and the American Diabetes Association, ADA, Diabetes Technology Working Group, entitled Challenges in and Opportunities for Individualizing Diabetes Technology. The authors involved in this document represent truly rock stars in the diabetes technology space, with the joint first authors being Professors Daniela Brutomesso and John Petrie. I am very happy to be joined by one of the many rock stars involved in this statement, Professor Lutz Heinemann from Dusseldorf, Germany. He is an engineer and a biologist and has been embedded in the field of diabetes technology for several decades. Thank you for agreeing to be part of this podcast, Lutz, and congratulations to you and the working group for this impactful position statement.
Thank you very much, Alice, for the very kind introduction. And I'm happy to discuss a little bit the topics that we have brought or tried to bring forward in our manuscript here.
Excellent. Thank you. So, to begin, can you please share with the audience why the working group decided to write this position statement? What exactly is a digital divide, as is described in the manuscript, and why should we work to close it?
So this publication, which is also published in Diabetology, the European journal, at the same time as it's now coming online in Diabetes Care, is the last publication of a series of similar statements that our working group has published over the last 10 plus years. So we published a statement about CGM system, insulin pumps, one about apps, AID systems, and now this one here about the individualizing of diabetes technology. So I think this number of papers reflects the rise of the relevance of diabetes technology as one of the pillars of modern diabetes technology. In our publications, what we try to bring forward is a neutral, independent, clinically focused, and also critical view on the different topics that we regard as relevant for diabetes technology and the clinical implications. Highlighting this is also of relevance that we each time have a series of recommendations on how to improve the situation with the given topics that we have dealt with. For example, the digital divide that you mentioned. I think in general, this is more a topic which is related to social differences, economic income, and so on and so on. So the number of aspects. Here we are a little bit more focused on what is probably a difference in the view of physicians, of patients on diabetes technology. Why are there some very techy interested, most often patients with type 1 diabetes that are really interested in diabetes technology? They most often, quite often, know more about the technology than the physician. And then in contrast, we have many of the elderly patients with type 2 diabetes that are not digital natives, let's say, and that are different. And we have to handle, and we might come back to this topic a little bit later again, we have to acknowledge the difference in the view of and the ability to handle all the technology day by day. I don't know about you, but for me, the daily fight with the updates, with the password changes, and so on, is somewhat of relevance. And I think there's some room for improvement to handle all the digital world. However, I think I should stop here. Otherwise, I'm continuing too long.
No, that was absolutely perfect. Thank you. So, within this statement, specific actions are suggested for healthcare professionals, for people living with diabetes, funding bodies, professional societies, as well as manufacturing companies, which really highlights the critical role that all stakeholders play in this space. So, let's start off with supporting people with diabetes to select diabetes technology. So, what are some of the things that we as healthcare professionals should do to provide that support?
So, when you just mentioned the different groups that are somewhat involved in all the usage of diabetes technology. If you have never tried to write up such a manuscript, I think it's really of interest to acknowledge how long time it takes until you have sorted out your thoughts and how many discussions each and every sentence generates that is in such a publication. And the aim here is clearly that we want to support the people by raising certain topics that are of relevance. And in the tables that we have included and the text boxes with certain actions, we try to support the selection of what is the best CGM system for the given subject. So I think there are some aspects, and again, I think we will come back to it, how to select for the given patient which pump or whatever device is the best one for him in his individual needs.
So, really individualizing and providing that education. Now, you also discuss specific populations within the document and the use of technology in those specific populations. And these included people living with impaired awareness of hypoglycemia, older adults, those who've had pancreatectomy or cystic fibrosis or post islet cell or pancreas transplantation. Can you share a bit about what we know and don't know about these specific populations?
Let me jump a little bit on this topic. If you list all the small groups, and we can prolong this list here by patients that are visually impaired, elderly patients, pregnant women, and so on, it's somewhat impressive to think about how many different groups with special needs we have. And if you sum this number of patients up, this is a large group, where many patients have special needs. And sometimes when you discuss with the industry, whatever that means, about why don't you have an insulin pump that is easy to use for elderly subjects, visually impaired subjects, they say, sorry, we have to design a device for the average patient. I'm not sure that there are too many average patients around. So I think we have to be able to somehow adjust the technology to the individual needs. And coming back to individualization, there is a need. And I think also that the digital world is of help in principle to be able to adjust the pump and its function to the need of a given patient. Some patients don't need all the settings that a modern insulin pump offers and so on. So just as an example. But I think the discussion, and we had a number of different patient groups here in mind when we have written up the manuscript, and we try to discuss also a little bit what is the evidence, what are the pros and cons in these groups and so on. And there are a number of, let's say, open questions that still exist. So our knowledge about the need of the specific populations is not bad, but it's also not good.
I really like what you said about taking the existing technologies and adapting them to the needs of the individual, because you're right, there is not a special tech for each specific population. So I really like that concept that you just shared. Now let's shift gears a bit and talk about optimal outcomes, because there's a whole section within the manuscript about optimal outcomes. And there's a sentence that particularly resonated with me. It read, "To achieve optimal outcomes, the focus should shift towards personalized care. Example, how can the available diabetes technology best be matched to each individual with diabetes, rather than crude metrics like X percentage of people on sensor or pumps?" So, can you explain more about how best to define optimal outcomes and the unfortunate role that healthcare professionals have played and unfortunately continue to play in contributing to disparities in access to diabetes technology?
So let me go back a little bit and think about the usage of AID systems. When I first discussed this with my colleagues and also with healthcare insurance companies and so on, so the group of patients they had in mind are the young, fit type 1 patients. However, it turned out that quite often the patients that have difficulties in having a optimal metabolic control are the ones that benefit most from these technologies. So, somewhat in contrast to what you might think at the first glance, what is the optimal outcome, is what the reality of patients with diabetes is telling you. And for some patients, even if they don't achieve a time and range of 70, 80%, an increase from 40 to 60 or 7% is a more of relevance, a bigger benefit than increase from 80 to 90% or so. So I think, again, thinking about the individualization, we should not say each and every patient or the average should be at 90% time and range. It depends on the individual need of the elderly subject or business or professional aspects that he has and so on. So the statement each and every patient should have a time and range at least above 70%. You can argue about it. In many patients, this is counterproductive.
Agreed. There's also a section on psychological barriers. And what I loved was it said psychological barriers for people living with diabetes, but interestingly, also for healthcare professionals. So please explain what you meant by that.
Yeah, and believe me, this was a topic we discussed back and forth quite a lot. So clearly, one important aspect, and this is for patients and physicians, healthcare professionals, is expectation management. So if you go to the big diabetes conferences, to the industry exhibition, to the booth, your impression is use this and this device and all your problems are gone. However, what we have learned is that even AID systems, where you think, okay, just hook them up, some settings, and then the system is doing everything itself. In reality, it's not that way. It's very helpful, don't get me wrong. However, again, if you have certain situations, diseases, exercise, whatever, technology come at a limit. And again, expectation management is a key aspect here. And if you have patients that have the impression, damned, I have only 90% time and range, but I have to achieve 100% or whatever, then you could put stress on the given patient. And I think we have to then also train the physicians, the healthcare professionals. Wait a second, what is the realistic aim here for such a system? So this is why also the healthcare professionals, and they have a different stress. If you are not attending all the technology meetings and so on, you might have the impression, oh, I'm not up to date all the time. The most recent developments, I have not heard about it. I'm not adjusting the diabetes therapy optimally and so on. So I think there's also some stress for the patient, for the physicians, for the healthcare professionals, especially in a time where the physicians don't have the time needed to handle the individual situation. So also from a economical aspect, probably my statements are mainly for the German European situation. If you have enormous numbers of patients that you have to take care of, can you really individualize the situation as you intend to do for a given subject? This is somewhat contradictory, as I would say, and we have to think about it. So, in principle, modern technology, think about remote monitoring and so on, allows you to take care of patients, but this is in practice not always easy.
So let's talk a bit more about that remote monitoring technology, because that was the final section within the manuscript. So what were the action items that your group suggested around remote monitoring?
So, what I also liked when you talk to young patients with type 1 diabetes, they say, why in the hell should I go? And this is a requirement with disease management programs in Germany. Why in the hell do I have to go in a busy practice every 3 months without any changes made to my therapy? I'm in a good shape. I know my diabetes. I know how to treat it well. So why could such a subject not have a remote communication, telecom consulting with his treating patient and physician? And this is what you need, yeah? If everything is fine, go ahead. There's no need for additional see a doctor. So I think the flexibility of the system is not there. You might argue, okay, if you only see your patients remote, you might not have the understanding of what's going on in the individual situation in his private life, professional life, and so on. Clearly, there are many of these aspects that are easier to communicate when you see yourself face to face. Nevertheless, I think there are options to perform the remote monitoring in a synchronous or asynchronous manner. So we can handle the interaction between the patient and the physician in a smarter way. And I think this is what we try to promote, especially, and like in the US or in Canada, wherever you have patients that are living in a remote place that for them it's an hour's drive to see a physician and so on. So I think that we will be able to have a better metabolic control if we use telemedicine in a smarter way.
I mean, COVID did not give us many gifts at all, but maybe the one that it did give us was the acceleration in the technology to allow us to do virtual care because it was forced upon us. And I agree with you. I think there are many scenarios where it is clinically appropriate for remote monitoring to take place, or some sort of hybrid model whereby you still see the patient maybe once a year or once every 18 months, but actually have touch points that are more virtual. So yeah, I agree completely. Now, Lutz, there's lots we could talk about, but I want to make sure we leave some stuff for our audience to actually read in the position statement. So I do want to give you the opportunity, though, to give us the big take-home message that you want to ensure our listeners have from this conversation.
Let me start with a probably unusual statement. I hope that you enjoy reading the statement. And we try to add a number of, as I try to indicate, of comments, of suggestions about things that you might be able to change in your private practice, that you can adjust to the needs of the patient. So it's not that we say you have to do this or that, but that we try to indicate where we see options to adjust the way how you handle diabetes technology, which I believe is really a pillar of modern diabetes therapy. And I think I also try to highlight that in the communication with the healthcare insurance companies, politicians, and so on. So we have to highlight that there is a need to have the resources, time to adjust the therapy to the individual needs. So technology, and clearly AID systems are the example for it, they are of help, big help, no doubt. However, I believe that the training of the patients is crucial. Also, the training of the healthcare professional. And training for us Europeans does not mean only how to handle the device, which knob to press or whatever, but also to understand how you can optimally use these medical devices to optimize your diabetes therapy. I think this is one of the key messages that we would like to send out with this manuscript.
Excellent. Thank you. Thank you very much, Professor Lutz Heinemann, for sharing your expertise with us today. And congratulations to you and your colleagues for creating this important position statement. I think it serves as a reminder to all of us to reflect on the role that each of us plays in ensuring adequate and appropriate access to diabetes technology for everyone living with diabetes if they desire it. It's a call to action to the many stakeholders to do their parts to address the digital divide that you alluded to at the beginning. So thanks again, Lutz, and I encourage our listeners to read the full article in the June 2026 issue of Diabetes Care.
In the June 2026 issue of Diabetes Care is a feature article entitled Hyperglycemia During Acute Pancreatitis and Progression to Early-Onset Diabetes After Recovery. Preliminary findings from the Diabetes Related to Acute Pancreatitis and Its Mechanisms, or DREAM study. I'm delighted we have joining us the article's first author, Dr. Kathleen Dungan. Dr. Dungan is Professor of Medicine in the Division of Endocrinology, Diabetes, and Metabolism at The Ohio State University Wexner Medical Center in Columbus. Welcome, Kathleen.
Hi, Michael. It's great to be here.
Congratulations to you, Kathleen, and your co-authors on this feature article. So for most of us, it's less appreciated that diabetes can develop after an episode of acute pancreatitis, as we think about it more often with recurrent acute and chronic pancreatitis. So, your dream team sought to understand this relationship better. Can you start by telling us about the overall design of your study?
Well, sure. The DREAM study is an NIH funded long term, that's multi center observational cohort study. And it was designed to establish the long term incidence of diabetes and after an acute episode of pancreatitis, and also identify the underlying metabolic and physiologic mechanisms. Within that context, we perform this analysis. Our inclusion criteria for the overall DREAM cohort is patients who've had acute pancreatitis within the last 90 days. And we did not include patients with diabetes, obviously, in this analysis, but overall, we did include patients with diabetes in the study as a whole. Exclusion criteria were chronic pancreatitis, any prior pancreatic surgeries or tumors, or patients who are on other immune modulators or corticosteroids that could impact diabetes incidence were excluded. And then all patients had a metabolic visit where we performed an OGTT, a fasting glucose, and an A1C on average about 111 days after their acute pancreatitis episode. And so we analyzed the baseline predictors during the AP episode and whether it was predictive of diabetes at that metabolic visit.
So, in your study, you identified hyperglycemia being present during the acute pancreatitis episode in 37.5% of your study cohort. And as you pointed out, these were all the individuals who did not have diabetes prior to this presentation. And so, what patient and disease characteristics predicted finding hyperglycemia during that episode of acute pancreatitis?
We identified several risk factors for hyperglycemia during the AP episode, and that included older age, which isn't unexpected, and also AP severity. And these remained significant after adjustment for other variables. In addition, there was an increased odds for persons of Asian versus white or Caucasian descent, and gallstone pancreatitis versus idiopathic etiology. So couple of things that require more ongoing investigation.
And so, except for the age, these disease specific characteristics appear to help distinguish the hyperglycemia during acute pancreatitis from those who did not develop hyperglycemia. And now, how well did identifying that hyperglycemia during acute pancreatitis predict future new onset diabetes shortly after recovery from the acute pancreatitis episode?
Hyperglycemia during the acute pancreatitis episode was actually a very strong predictor of new onset diabetes after recovery. About 15% of those who had a glucose over 140 had diabetes versus only about 1.2% in those who didn't have hyperglycemia, so good at ruling it out. And for the other cutoff, we studied 200 milligram per deciliters. The differences were even more pronounced. So 43% had diabetes with a glucose over 200 versus only 3.5% of those without. So in general, individuals who did not have hyperglycemia were at very low risk of developing diabetes in the short term, whereas those with glucose over 200 were at highest risk, although not 100%.
And your article points out that currently the American Diabetes Association recommends that we screen for diabetes at 3 to 6 months following an episode of acute pancreatitis and annually thereafter. And we all know how complex transitioning care from an inpatient stay to outpatient setting can be for both our patients to navigate and for our practices to coordinate. So, how might these findings from your study influence our future screening recommendations?
I think that's an important consideration as the transition from the inpatient to the outpatient settings can be really complex. and have lots of challenges for patients to navigate, especially if they have limited ability to attend their clinic visits. That patients with pancreatitis often have other socioeconomic barriers and medical comorbidities. And the finding that hyperglycemia was highly predictive of diabetes provides some evidence supporting rationale for early screening. On the other hand, the very high negative predictive values suggest that we can implement a longer interval for screening in those who don't have hyperglycemia.
Yeah, and I think that is so helpful in thinking. I know in my own practice, a lot of individuals like to think that when there is hyperglycemia during hospitalization, oh, you didn't have diabetes before, this is going to go away. And often they're discharged without appropriate follow-up or even the tools to monitor with even a finger stick blood glucose meter. And I know when consulted on those cases, I try to be pretty insistent on, well, hey, let's just go home with the blood glucose monitoring meter so that we can keep an eye on this. And I think that that does help in determining who does need more attention at the time of discharge and being able to say, oh, no, glucose was really fine throughout your hospitalization. We can think about your diabetes screening as part of your longer term care is really helpful for deciding on when it's important to emphasize those added measures. And so with that, what do we have next for the DREAM study, and what additional questions are you looking to address with the ongoing follow-up that's planned?
Well, the overall goals of the DREAM study are long term follow up. And so we don't know from this analysis what those long term outcomes will be. And so we are going to continue to study that. In addition, we hope to further refine the utility of various screening tests. For example, in cystic fibrosis, the oral glucose tolerance test outperforms the A1C and the fasting glucose, but that can be challenging to operationalize. And so in the near term, we'll be looking at comparing each of these different diagnostic tests for diabetes as well.
Kathleen, what final takeaway messages do you have for our listeners?
I think it's important to study hyperglycemia during acute pancreatitis, and it's distinct from your typical stress hyperglycemia from a hospitalized patient because now not only do we have all those other illness related factors that contribute to hyperglycemia, but we have the potential for direct injury to the beta cells. And so that trajectory of diabetes could differ quite significantly, and this will help us facilitate the coordination of care. And long term, we can use that to hopefully even help identify preventive strategies, as many of these patients have common risk factors as people with type 2 diabetes, and eventually, hopefully, good treatment options.
Yeah, and I think that's so important how thinking about the hyperglycemia that might be present during hospitalization for acute pancreatitis can really be indicating something else that's wrong in the pancreas and not just be dismissed as being related to stress of being hospitalized for acute illness as in many other conditions, and to pay closer attention to those individuals. So I really want to thank you so much, Dr. Kathleen Dungan, for sharing your expertise with us today. It's really been important for me to learn about the prevalence and the predictive power of identifying hyperglycemia during acute pancreatitis. And I agree this should be really helpful for identifying earlier those at risk and improving control ultimately of any diabetes that might develop for affected individuals if not being able to prevent it. So I really encourage our listeners to access the full article in the June issue of Diabetes Care. Let's move on now to the Rapid Exchange segment, where Alice and I will discuss articles we found of particular interest this month. Alice, can you kick us off, please?
Total transparency, Mike, I am going to cheat this month. There were a number of articles that I wanted to talk about, so I'm going to shorten and combine, at least in this first round. The theme is around risk prediction value of central obesity. Dr. Erika Parente and colleagues from Finland investigated the relationship between central obesity, defined as waist to height ratio of 0.5 or greater, and coronary artery disease across albuminuria categories in type 1 diabetes. Using data from the Finnish diabetes nephropathy study, they identified 4,349 individuals with type 1 diabetes and no prior CAD. Among this cohort, 664 had an incident CAD event during the median follow-up of 19 years. The 10 and 20-year cumulative CAD incidents were 11.6% and 25.3% among those with waist-to-height ratios of 0.5 or greater, compared to only 4.4% and 9.9% among those without central obesity. Each 0.1 unit increase in the waist-to-height ratio raised the CAD risk by 21%. Now, along the same lines, Dr. Anna Rosen-Valmar and colleagues from Kaiser Permanente, Northern California, examined associations of early pregnancy central obesity with gestational diabetes, hypertensive disorders of pregnancy, postpartum prediabetes or diabetes, and postpartum chronic hypertension. The data from over 3,000 pregnancies demonstrated a dose-response relationship between increasing central obesity and all outcomes, even after adjusting for BMI. Importantly, among those with normal pre-pregnancy BMI, central obesity was still associated with higher risk of GDM, postpartum prediabetes or diabetes, as well as postpartum hypertension. So these two studies further support the critical role that central obesity plays in cardiometabolic diseases in a variety of populations, including type 1 diabetes, as well as pregnancy.
And as important assessment of central adiposity is for cardiometabolic disease risk, as these two studies so nicely remind us, we've still largely failed to implement a waist to height ratio. And in fact, Alice, I was thinking this was waist to hip ratio. And as I understand now, the waist to height ratio, well, that's maybe more robust and even easier because it requires just getting a waist circumference added to height, which is already being routinely measured in clinical practice. And actually, we rarely do this in waist circumference in routine endocrinology practice. So it's really great to see more evidence accumulating for this anthropometric becoming a fifth vital sign collected during intake assessments and easily calculated from a waist circumference and the height into this ratio as we already do for BMI. So that's really great. I'm going to tell you about a related pick from this issue that's examining the contributions of visceral and hepatic fat to metabolic dysfunction in overweight adolescents and young adults of South Asian ancestry compared to those of white and African American ancestry living in the United States who took part in the Charisma study. And here the overweight's being defined by BMI above 23 because that can already be associated with ectopic fat deposition, particularly in South Asians. And so Dr. Talia Hitt from Baltimore, Maryland, and colleagues evaluated approximately 50 adolescents and young adults of each ancestry, matched for sex, pubertal stage, BMI Z-score, and waist circumference. And while they did also take heights, they didn't report specifically the waist to height ratio. And they evaluated each individual with magnetic resonance imaging, magnetic resonance spectroscopy to quantify visceral and hepatic fat and perform frequently sampled oral glucose tolerance tests with mathematical modeling to quantitate insulin sensitivity and secretion. And they found that those individuals of South Asian ancestry had more visceral and hepatic fat and lower insulin sensitivity and dynamic insulin secretion, but a higher static and total insulin secretion than their white and African American peers. And so these findings suggest an early propensity to ectopic fat accumulation and insulin resistance developing in South Asian youth that likely precedes later beta cell decompensation that may explain the higher risk for developing type 2 diabetes that's seen in South Asian adults.
You're completely right, Mike. This further supports the importance of identifying these at risk individuals with simple office measures. And I think things like the waist circumference, and if we can now add the height to it, waist to height ratio is an important message to send, especially to our primary care colleagues who are seeing these individuals before the obvious clinical cardiometabolic changes have occurred, but we can easily then identify at risk people. And clearly, in young adults and adolescents, that's already an issue. So, my second pick is a beacon of hope to adults who do not engage in regular leisure time exercise. And you know who you are for those who are listening. So, Dr. Kar Hao Chong and colleagues from Australia, Canada, Denmark, and the UK utilized prospective data from UK Biobank accelerometry sub-study participants to examine the dose response associations of intermittent lifestyle physical activity with incident type 2 diabetes. Now, this refers to brief and sporadic bursts of incidental activity that occur throughout the day, such as running to catch a bus, carrying groceries, or mowing the lawn, that can be picked up by wearable technology. They classified these as either vigorous, intermittent lifestyle physical activity, which are bouts lasting less than a minute, or moderate to vigorous intensity, intermittent lifestyle physical activity, which they defined as bouts lasting less than 3 minutes. The primary outcome of the study was incident type 2 diabetes. The sample comprised of over 22,000 non exercising adults with a mean age of 62 and about 56% female, with 665 incident type 2 diabetes cases over the average follow up of 7.9 years. What they found was that these bite sized physical activity bouts reduced risk of developing type 2 diabetes. Median durations of 3.9 minutes per day of vigorous intermittent lifestyle physical activity and 25.3 minutes per day of moderate to vigorous intensity intermittent lifestyle physical activity were associated with 36% and 46% lower risks of type 2 diabetes, respectively, compared to no vigorous or only 3.9 minutes per day of moderate to vigorous. Daily frequency of 10.4 bouts of vigorous intermittent lifestyle physical activity corresponded to a hazard ratio of 0.64 compared to 0 bouts per day. This means that for adults who do not engage in structured leisure time exercise, accruing brief intermittent bouts of moderate to vigorous physical activity during day-to-day routines can still reduce risk of type 2 diabetes. So in other words, take the stairs if you can, park farther, and walk briskly to the store. Carry your groceries if possible. Just think of little things that you can do on a day-to-day basis that is not structured exercise, but that will allow you to fulfill some of these requirements from a frequency and intensity perspective that will then allow you to reduce the risk of developing type 2 diabetes.
Yeah, thank you, Alice. It's so great. Those short bursts of just getting the heart rate up and the blood pumping is so important for organ function. And it's nice to see evidence for benefit of this advice that we've been giving for a long time now, really showing up in outcomes for our patients. So making small but intentional adjustments to daily life can really have such important effects for long-term health. Again, now I'm going to relate my next pick to yours again, Alice. For those with type 1 diabetes who are engaged in structured leisure time exercise, we know that the concern for hypoglycemia is always top of mind. And this gets back to my article we discussed at the start of this episode in without a physiologic glucagon response to during, which also does not occur in type 1 diabetes during exercise, to tell the liver to make the additional glucose required by muscle to support activity. And so how do we manage this with individuals with type 1 diabetes? And Dr. Jennifer Leor from Indianapolis, Indiana, and colleagues examined strategies for reducing the insulin on board at the start of exercise with ultra rapid Lispro, which is also known as Lumjev, compared to standard Lispro or Humalog insulin among 25 conventional insulin pump users with type 1 diabetes. Two strategies were tested in a crossover design with each insulin. Those two strategies were either a 50% reduction in basal rate of insulin delivery starting 60 minutes prior to the start of exercise. And the second was a 100% basal rate reduction, just turn off the pump 15 minutes prior to the start of exercise. And the exercise consisted of 60 minutes of aerobic activity at 55% of a VO2 max, so a moderate intensity aerobic activity. And with both strategies, the plasma lispro concentration were lower during exercise with Lyumjev than with Humalog, and there was less of a decline in glucose concentration observed when using Lyumjev compared to Humalog. But also what they found was that the 50% basal rate reduction 60 minutes prior to the start of exercise was much more effective than the 100% turn off 15 minutes prior to exercise. And so this tells us that for Humalog users, employing a basal rate reduction strategy, if you are able to make a change well before exercise starts, the faster action of Lyumjev may enable you to experience less exercise-associated hypoglycemia. But we still need comparisons of Lyumjev with the other rapid-acting insulin analog, Aspart or Novolog, or its ultra-rapid counterpart, Fiasp, in the future.
This is useful information for our patients because we all know the benefits that exercise can bring and the potential dangers of hypoglycemia during it. So it's great that these data are available and options are available to our patients. Now, I'm sure that everyone listening is aware of the common phenomenon of people having different weights in the winter compared to the summer. Now, usually these seasonal weight changes are dismissed in the clinic, but maybe it should not be. My final pick informs us that weight cycling has negative effects not only on cardiometabolic outcomes, but also on kidney function in type 2 diabetes. So, Dr. Ryota Toki and colleagues from Japan analyzed a cohort of 6,700 people from the Japan Diabetes Clinical Data Management Database, which is a multi-center diabetes registry collecting longitudinal clinical data from specialist clinics and hospitals across Japan. Over a median follow-up of 6.8 years, they determined that each 0.2 kilogram per meter squared, or 1 standard deviation, larger seasonal BMI swing between summer and winter was associated with a 23% higher hazard of a 40% or more EGFR decline. The hazard ratio for EGFR decline between those with the highest tertile of BMI change compared to the lowest was 1.7. Therefore, routine seasonal weight tracking may help identify the higher risk patient. Of course, what is not known is whether preventing seasonal BMI fluctuations can actually improve kidney outcomes. But this study certainly makes one pause and realize that, hang on, these shifts in weight that happen between summer and winter are perhaps not as benign as we once thought.
And perhaps also, Alice, it makes me think about our discussion earlier whether maintaining regular physical activity throughout the colder months could be occurring in those who are avoiding seasonal BMI fluctuation. And that's also helping to preserve kidney function for those individuals. My last pick goes in a different direction. Our current champion of the ambulatory glucose profile, Dr. Richard Bergenstahl from Minneapolis, Minnesota, together with colleagues from the GRADE Research Group, compared the continuous glucose monitoring profiles associated with the 4 classes of glucose-lowering medications used in combination with metformin in the glycemia reduction approaches in diabetes randomized clinical trial that involved individuals with type 2 diabetes. The present analysis is based on a 2-week mass collection of continuous glucose monitoring data that occurred after about 2.4 years of follow-up in over 1,000 participants. And they were receiving either insulin glargine, the sulfonylurea glimepiride, the DPP-4 inhibitor sitagliptin, or the GLP-1 receptor agonist liraglutide in the randomized design. What they found was that the sitagliptin and liraglutide groups had the highest time spent in the target glucose range of 70 to 180 milligrams per deciliter, or 3.9 to 10 millimoles per liter, and spent the lowest time below range, less than 70 milligrams per deciliter, or 3.9 millimoles per liter, and also had the lowest percentage coefficient of variation as a measure of glucose variability. While the glimepiride group had the least amount of time spent in the target range and the highest percentage coefficient of variation and the most time spent below range, as well as number of CGM-derived hypoglycemic events, which corroborates evidence from the parent study in higher blood glucose documented hypoglycemia with glimepiride. And the insulin glargine group sort of sat in between. So while the parent trial showed that glargine and liraglutide were more effective at achieving the hemoglobin A1C target of less than 7%, now seen, albeit during a cross-sectional snapshot in the middle of the study, is that sitagliptin and liraglutide were the best for achieving CGM targets of time in range. So more in these groups had time in range above 70% as recommended by the American Diabetes Association, as well as more were able to achieve the ADA's time below range target of less than 4%, and also had lower glucose variability. And so these findings really highlight how in type 2 diabetes, as been established in type 1 diabetes, evaluating CGM metrics can really complement traditional hemoglobin A1C measurement in assessing an individual's response to intervention and help to guide management decisions.
And it's always nice to see CGM data with non insulin therapies as well, because depending on where one lives, access to CGM for those not on insulin may not necessarily be there. So it's always lovely to see these data really supporting what we expect to happen from a clinical perspective. Well, this brings us to the end of the June 2026 episode of Diabetes Care on Air. Big thank you to Professor Lutz Heinemann and Dr. Kathleen Dungan for sharing their expertise with us.
And a reminder to all that Diabetes Care Journal is continuing to take submissions of original art for consideration to be included on a future journal cover. So don't be shy. And don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening to another episode of Diabetes Care on Air.